Good afternoon and good morning to everyone. I'm Mohammed Yunus, Gallup's editor-in-chief, thanking you for joining us today for this discussion on why Americans are so worried about rising healthcare costs and what can be done about it. The burgeoning crisis of healthcare costs and associated debt is a critical issue on the minds of most Americans. With the election on the horizon, we find that 35% of Americans cite a candidate's position on healthcare as extremely important. Historically, we know that almost in every election we've polled in, healthcare and the economy are the two most important issues on the minds of voters when they go to vote. While high costs have been problematic for decades, the pandemic has further exposed the persistent cracks and disparities of the healthcare system here in America. Today, my colleagues from West Health and Gallup, along with a group of true thought leaders on healthcare research and policy, will shed light on America's healthcare cost crisis and propose possible solutions. On behalf of Gallup, I first just want to thank West Health for their partnership and work at exposing and addressing the harsh realities facing too many Americans when it comes to healthcare. To kick us off, we'll hear from West Health's President and CEO, Shelley Leifert. Shelley oversees West Health's family of nonpartisan, nonprofit organizations that are dedicated to lowering healthcare costs and improving the lives of the nation's seniors. West Health uses a multifaceted approach to tackling these challenges through their various focuses on applied medical research, policy, and outcomes-based philanthropy. Shelley also leads the Gary and Mary West Health Institute as it conducts research on a wide range of healthcare issues affecting seniors and their families. Shelley, welcome to the conversation. The floor is yours, ma'am.
Great, Mohammed, thank you. I'm so pleased to welcome you to this important discussion about healthcare in America, something so central to our lives and more important than ever in the midst of a pandemic that has upended our world and exposed both the strengths and weaknesses in our system. Chief among these weaknesses is the high cost of healthcare, which even during a pandemic has made people hesitant to seek medical services. Millions find themselves more worried about the cost of getting sick rather than the illness itself. Unfortunately, this is the America we live in. As we face the newest and greatest public health threat in our lifetime, we still must confront the oldest and most enduring health threat of high-priced prescription drugs, treatments, insurance premiums, and out-of-pocket costs. Sadly, this is the reality of healthcare in America. What good are the life-saving medical advances and breakthroughs our physicians and scientists achieve if they are out of reach to most Americans? All these issues and more have been uncovered through West Health's ongoing partnership with Gallup. Our goal has been to illustrate the challenges and hardships Americans face every single day, give voice to their concerns, and make it harder for politicians to ignore the cries for help from their constituencies. There is too much at stake for more empty promises from politicians, unchecked prices from pharmaceutical companies, and a healthcare system that rewards volume of services over the value of outcomes. The stories of Americans struggling with our broken and high-priced healthcare system are heartbreaking. And if things were bad before, the pandemic has made them even worse today. As you will hear in this session, many people are not only fighting a virus, they're living in fear at what it will cost them. Some are worried about their livelihoods, and others are paying with their lives. According to one of our recent surveys, millions of Americans feel they are but one health event away from bankruptcy, and millions more indicate they would not seek care even if they had symptoms of COVID-19 out of cost concerns. But if these issues didn't just emerge because of COVID, they have become even more obvious today. For the longest time, American families have been forced to make gut-wrenching choices between healthcare and food, or healthcare and rent. And it doesn't have to be this way. We pay a lot for healthcare in this country. In fact, more than any other developed nation, and we are not getting our money's worth. Not even close. However, with determination, smart policy, and the American public on our side, we can accomplish so much. Public sentiment is everything. It can even move non-responsive, recalcitrant politicians and entrenched special interests, particularly in an election year where healthcare is on the ballot. In fact, our surveys consistently find healthcare is a top issue for voters and will influence whom they vote for, as it should. It's very clear that a confluence of events, including COVID-19, runaway healthcare costs, divisive politics, and increasing disparities amongst groups of Americans has put our country at a crossroads. Now is not the time for incremental change. Now is the time for bold action. We need to meet the moment, and the moment is now. Thank you.
Shelley, thank you for that powerful message. Now let's take a look at some of those key findings Shelley mentioned that Gallup and West Health have been working on gathering together and sharing with the public. Today, we have a special treat to have those findings presented by Dan Witters, Director of Gallup's National Health and Wellbeing Index, and also West Health's Chief Strategy Officer and Executive Vice President, Tim Lash. Tim oversees the development and execution of West Health's successful aging portfolio across its nonprofit applied medical research, policy initiatives, and outcomes-based philanthropy. Dan, as I mentioned, serves as director of the Gallup National Health and Wellbeing Index and leads much of the well-being research Gallup does with various communities. Dan, Tim, the floor is yours, gentlemen.
Great, thanks, Mohammed.
Thanks, Mohammed. Hello, everybody. Hello, Tim. It's great to be here today. We've got some great results to share with you all as a part of the partnership that Gallup and West Health have had with one another. Started in that relationship in 2018. In early 2019, we administered our first nationally representative poll across the U.S., have done 7 additional polls since that time. Some questions we've asked more than once, so we have some trend data that I'll share with today. Other questions, brand new, that we've just recently gathered. So hopefully this will be useful for everyone who's paying attention, who cares about this important topic. We can, I think, kind of roughly drop this into 3 different categories, everyone. We'll talk about the physical and emotional and financial toll of the healthcare cost crisis. We'll get into COVID, of course. That's going to constantly overlap with healthcare for obvious reasons. And then leave off with some comments on drug prices and the role of government.
And Dan, just on this before we move on, just before we head into the slide here, just thought it's important to just highlight something that Mohammed and Shelley really alluded to, right? And that's that there is a truth in the country that healthcare simply costs too much, and that impact transcends, as we know, politics, income, race, age, and as Dan, you just pointed out, COVID-19 really has shined a new light on the reality of healthcare as it is in the United States, and the surveys that we're going to go through, I think, will really illuminate that. But I just really want to emphasize just how relevant this information is at this moment. As we think about it, we will be electing the leadership that is going to establish the healthcare agenda for the next 4 years. And the information that Dan, you and I will be sharing, and the panelists will be sharing, as well as patient advocates, is really critical to be surfaced at this very moment, because it needs to inform the decisions that we make over the coming weeks. And it needs to really cause us to engage in a way that perhaps we haven't engaged before, to really shape the agenda for healthcare in a direction that yields the outcomes that all of us really do deserve.
Thanks, Tim. That's a perfect setup for the next slide, starting with some high-level results that we want to start out of the gate with. This is a big deal for the American public. We have 28% who are now reporting that they've had a health problem in the prior 12 months for which they did not seek care due to the cost of health care. That's up from 26% in early 2019. We've got another 24% reporting they're unable to pay for medicine for themselves or someone else in their household due to costs in the prior 12 months. That's up from 19% in early 2019. And we're now sitting at 50% who fear bankruptcy due to a catastrophic health event. That's up from 45% from early 19. So, Tim, these are big numbers. They translate to really significant numbers of individuals walking around. There are 254 million American adults right now. You can do the quick math, 28% that aren't seeking care due to cost. That's 71 million people. 24% unable to pay for medicine over a 12-month span. That's another 61 million people. So very real, very significant, and affecting lots of people.
No doubt, Dan. Certainly this information really does, I think, at the individual level, paint a grim or dark picture for the experiences that us as Americans, as individuals, as families are experiencing. As we go through this data, what I'll try to do is contrast it with some of the macro dynamics that we're facing. Sometimes that changes the story. I think, unfortunately, as it relates to the experience for the individual versus the broader sort of macro level, the future is no brighter. If we look at 2020, the spending on healthcare has surpassed $4 trillion. If we look at Medicare spending alone, it's over $850 billion. That's over 20% of our total national healthcare expenditure. It's simply unsustainable at the macro level, and as this data yields, it's simply unsustainable at the level of the individual as well.
Well, this manifests itself in different ways. One question that we've asked a couple of times has to do with borrowing money to pay for care. This hovers right around 11 or 12%, both in 2019 and in 2020, of U.S. adults that have had to borrow money in the prior 12 months to pay for a health care bill, amounting to $88 billion per year that's being borrowed. We've got about another 13% of American adults, just a slightly higher percentage, that are having to withdraw money from currently existing savings that's not dedicated for health care, savings that's dedicated for retirement or other forms of long-term savings that they have to pull out. And based on self-reports of the amount withdrawn, that's $126 billion per 12 months. So, Tim, not only are people foregoing care because they can't afford it, there's a high percentage of people that are paying for care either from borrowing it or pulling money out of savings that was meant to be used for something else.
No, that's great. And, here too, Dan, I think there's a contrast that really needs to be sort of emphasized. And if we compare and contrast these findings to what we know about the healthcare industrial complex, and specifically I'd like to focus on the pharma sector, back to Shelley's point on it doesn't have to be that way. It really doesn't. There's some misperceptions that are far too pervasive, just across the sort of the public's mind and an understanding of the challenge. And I think far too often what we see is individuals and families suffering, and it's a result of profits being prioritized above the patients. And just before we got on this webinar, I did just do a little quick check with the website GoodRx, a very good data source on what's happening with the pricing of prescription drugs. And if we look just at the past 6 months in 2020, 850 brand name and generic drugs have all experienced price increases of just under 10%, 6.8% in fact. And that really, I think, yields a situation where big concerns are obviously present, and they're justified. I think too often we say as individuals, and I'm sure I've caught myself on with this talk track at home and the dinner table talking to the family of, well, like life-saving things are happening, particularly within COVID. We're thinking about vaccination medications and therapeutics, et cetera. And you can easily say, well, perhaps we have to spend this much so that, or perhaps we even have to borrow money so that we can have these life-saving therapeutics. And unfortunately, that just doesn't hold true. We've done some analysis at West, looking at the profitability of the pharmaceutical sector. And what we find is that, one, the pharmaceutical sector is the most profitable sector in our economy. Two, if you took $1 billion worth of sales away from that sector over a 10-year period and maintained R&D investment at its current level, it would still be the most profitable sector, in our economy. So when we look at, individuals borrowing money, fearing bankruptcy, and as we'll see later in this data, often skipping treatments, it doesn't need to be that way. It is that way because, profits, are, being maintained at an unacceptably high level.
Well put. That sets up my next slide beautifully. Amid all of the things, Tim, that you were just describing, we also find a very distinct racial divide in terms of the financial burden that's carried by Americans as a function of the healthcare cost crisis. So again, about 11 to 12% are borrowing money in any given 12-month period to care for someone in their household. But that's 16% among non-white adults compared to 8% among white adults. We also find that about 15% of U.S. adults report that they currently have medical debt that they will not be able to repay in the next 12 months. So chronically carrying debt as a function of their health care. Again, much higher, 20% for non-whites compared to 12% of white adults. And then finally, 26% would have to borrow money to pay a $500 medical bill, much higher, 43% non-white adults compared to 17% white adults. Should clarify here that I'm talking about non-Hispanic whites. So when I'm talking about non-white adults, I'm talking about, that includes Hispanics as well. Tim, these are big differences, the way in which these kind of burdens are getting experienced depending on the color of skin that you have in the United States of America.
Yeah, no doubt, Dan. We're certainly seeing a significant increase on the racial, socioeconomic, even sort of political facets regarding the cost of healthcare and the impact that it has on our daily lives. The inequities that persist in our system are gut-wrenching. I was reading the other day that, in the year 2020, an African-American newborn in some wards of New Orleans has a 20-year difference in their life expectancy. That's simply something that we can't tolerate. But the real-life consequences of the high cost of healthcare are not isolated to small cohorts. It really does impact all of us. I think it's easy for us to think about, well, there's a segment of the population that has, really, sort of negative outcomes as it relates to cost or quality of care or the clinical outcomes they experience. But then all of the rest of us are really getting first-rate, cutting-edge healthcare. And it's simply not true. If you look at the data, it is true that the top 1% from a socioeconomic standpoint of our population do get the best healthcare and the best outcomes. But as you move to the top 2% and 3%, with each 1% decline, there's almost a linear relationship in a negative way, where we see worse outcomes, more struggling, and then you start looking at the impact of racial inequities on the outcomes associated with healthcare. And as I offered with the example with a newborn in New Orleans, it's something that I think none of us as humans can tolerate, and certainly none of us as Americans should tolerate as well.
Yeah, well put. Let's go ahead and transition now into some COVID-related content. First, having U.S. adults rate the national response. There have been different surveys taken kind of related to this. Ours, by design, is focused a little bit differently. We structured our question to read, relative to how much the U.S. spends on healthcare, do you think the national response to the COVID-19 outbreak has been excellent, very good, fair, or poor? Nationally, 57% of U.S. adults are rating it as fair or poor. Only about a quarter are rating it as excellent or very good. And we find differences based upon subgroups. So, for example, with education, I'm showing you the percent that are rating it poor right now. That is inversely related to education. About half of people with a postgraduate degree give the U.S. response failing marks, compared to 23% with a high school degree or less. Also inversely related to income. Again, about half of individuals inside of households with at least $100,000 in income per year give the U.S. failing marks, compared to 25% in those lower income households. And yes, we certainly find a political divide. 61% poor among Democrats compared to 11% among Republicans. I took a look at the top two box and the bottom two box percentages and combined them together. If you're a Democrat, just 6% rate the response as excellent or very good, compared to 84% who rate it as fair or poor. Independents, 20% excellent or very good, compared to 57% fair or poor. Only with the Republicans are they right side up on this one. 44% excellent or very good, compared to 28% fair or poor. So there is quite a difference, Tim, in how people inside of the U.S. all going through this pandemic together, but seeing the response through very different lenses.
Yeah, no doubt. And it's almost a tale of two cities, right? So, when we look at the experience that we've experienced with COVID, no doubt there was heroic measures taken by frontline healthcare workers and, community providers to do the very best that they could do to meet the needs of, individuals that, were affected by this horrible virus. But the reality is there were weaknesses that were really magnified by COVID that shouldn't be there. It's unacceptable that frontline workers didn't have the PPE. We didn't have a healthcare system that had the agility to flex its capacity and project care into the community. And often that was a function of how we pay for healthcare. As we look at organizations that are at risk, so think accountable care organizations or other healthcare organizations that are paid for their value they deliver rather than the services that they provided. Those organizations, had already built, ahead of a pandemic, the infrastructure to be able to flex their capacity, to be able to reach into the community, to have broader community health measures. And I think as part of that, we see this sort of, the data and the findings that there are bright spots that some folks have experienced, but more often than not, families and individuals have struggled under COVID. On the political side, I think this is a challenge. Related to, how is it really versus how do we perceive things or how do we want it to be? And I think that's where we're at a crossroads right now as a country to define not what we believe it to be, but to really have an honest discussion around how is it really and what do we want it to be moving forward, and then take the steps to make sure that we're establishing an agenda from a healthcare perspective, both in DC as well as the state level, that really will yield the outcomes that we all really do deserve.
Yep. Well, Tim, there was, I think, kind of a bit of a blind spot in measurement regarding COVID, and it was one that I was very happy that West Health and Gallup filled. One question that we asked is if you or a family member had a fever and a dry cough, would you avoid seeking treatment due to concerns about cost of care? The list of symptoms associated with COVID, of course, has grown over time. Some are more major than others, but the high fever and the persistent dry cough remain kind of the big two. And we discovered that 14% of U.S. adults, that's about 35 million people, report that they are members of a household suffering from these symptoms would not seek care due to costs. And so on top of everything else we know, there's this other kind of hidden piece. And we were able through this to reveal it through our research. I'll go ahead and drop in the deadly 22s here, 3 in a row. 22% of non-white adults would avoid care due to costs. That's double their white counterparts. 22% of Americans with no more than a high school degree would avoid care, compared to 4% of those with a college degree. And then finally, 1/5 of young people under 30 would avoid care, compared to 9% of those over the age of 50. Part of this, I think, is going to be health literacy, either a poor understanding of what the key symptoms are, or a lack of appreciation for the seriousness of those symptoms. A lot of this, though, is going to be socioeconomic status, including health insurance coverage. We know that folks under 30 have much higher uninsured rates than those over 30. We also know that Blacks have elevated levels of uninsured rates, Hispanics even more so. All three of these groups, Tim, have their uninsured rates have declined over the course of the Affordable Care Act era, but remain elevated. So you have kind of this witch's brew of factors that come together. And for these particular groups, especially, over 1 out of 5, even if they have known principal symptoms of COVID, are just not going to seek out care because they're afraid of what it's going to cost them to do so.
No, great points. Dan, I'd just like to touch on, one, the health literacy component, and two, just the broader fear, right, of accessing our healthcare system and the costs associated with it. On the literacy, here we know, because the data is very clear, that there are, major sort of racial inequities as it relates to health literacy. And, not only does that yield, a situation where individuals are delaying or not seeking care, but what we know is that in the Black community, as an example, the comorbidities that are particularly troublesome for COVID, so cardiometabolic disease or heart failure, that those have much higher prevalence. And the impact of those used to sort of, materialize over years to decades in terms of differences in mortality. And with COVID, those materialize over days to weeks. And then as it relates to just, individuals seeking treatment, certainly some have delayed treatment because of, for COVID, but we're seeing others delaying treatment, just because they're scared of the system. And if you look at the excess mortality, the number of expected individuals dying in a weekly period versus those that actually have died, COVID explains about 2/3 of it, where 1/3, is very likely related to individuals with other chronic conditions simply not getting the health care that they need.
Well, 2020 has been a particularly tumultuous year in terms of race relations in the U.S. It's racial tension meets pandemic. We ask, how concerned are you that you'll not be able to pay for the cost of care if you are in fact diagnosed with COVID-19? Extremely concerned, not very concerned, or not at all concerned. And there's a pretty substantial difference that we find here. 58% of non-white adults are either extremely concerned or concerned, compared to 32% of their white counterparts. We know, Tim, that the people of color in the U.S., Black and Hispanic adults in particular, are disproportionately suffering the effects of COVID. They are disproportionately suffering the effects economically. They are disproportionately suffering the effects clinically. CDC just released, I think it was 4 days ago, updated statistics that show that the mortality rate for Black adults is now running 50% higher than what we would expect probabilistically based on how many of them there are in the U.S. Hispanics mortality rate are running 31% higher than what we would expect based on how many of them there are. Layer into that now concerns about cost, about paying for this, about the cost of care if you get it, and you get kind of a third piece to this that really, I think, is vividly revealed with our data.
No doubt. I think it's so important that we're surfacing and sharing this insight right now. We've had in the past opportunities to create equity. We have that opportunity now. We have to do it. And I think this specific findings really do need to inform how we think about leadership moving forward.
We have just very recently asked, which presidential candidate do you trust more to lead the U.S. healthcare system most efficiently in addressing the COVID-19 pandemic? So again, this one's structured a little bit differently from how other organizations have tried to measure it. This one, by design, is in the context of the U.S. healthcare system. It's 52% for Vice President Biden compared to 39% for President Trump. Big gender divide, 58 to 32, if you look at women versus men. And a big age divide as well, 62% Biden compared to 25% for the president among adults under the age of 30. Tim?
Dan, I think we've witnessed some divided and distracted leadership, and I think what this survey shows is that the American public has woken up to that. If we don't have trust in our leadership to do the right thing during this pandemic, we certainly won't have trust for them to do the right thing in managing the U.S. healthcare system moving forward. And I think, unfortunately, for too long we've just been burned by empty promises. And I think the cost of prescription drugs is a great example of that. Right, for 4 years we've seen indications, of intent to do something, but with sort of little action. And as I pointed out earlier in this discussion, what we've seen is 850 plus drugs just in the past 6 months go up almost 10%. So I think there's reason for people to be concerned and reasons for our survey respondents to indicate that we're just not doing what we need to do, both with the pandemic and the overall management of healthcare in the United States.
Well, we're into the home stretch on our slides before we'll go over to our terrific panelists. There are a couple of real high-level findings that we have here that I'm going to drop in. 3 out of 4 Americans feel relative to their quality of care are paying too much for their care. 3 out of 4 are concerned or extremely concerned that rising healthcare costs will result in significant and lasting damage to the U.S. economy. One thing that struck us, Tim, when we first looked at these numbers is just how consistent this is across political identity. For the 76% who think that they're paying too much relative to the quality of care that they're receiving, 81% among Democrats, 76% among independents, and 73% among Republicans. So vanishingly small differences. The general perspectives on this are quite consistent regardless of political identity.
No doubt. And, Dan, as you pointed out, Mohammed and both Shelley, that when you just look at the outcomes and quality of care in the U.S. versus development nations, infant mortality, life expectancy, we fall behind. But there's this sort of false belief that we justify our high prices because we get the better outcomes. And perhaps as we dispel that myth, we'll have more support, more engagement, more commitment to the smart policies that actually do improve outcomes and lower cost.
Yeah, and we've again got pretty significant majority that thinks that the government is not doing enough to ensure that prescription drugs are affordable. That is a sentiment that is not just lingering, but festering across the U.S. adult population. And a little bit of a partisan divide, but not much. You've got pretty substantial majorities, whether Republican, an independent, or a Democrat.
No doubt. I mean, look, I think the cost of prescription drugs, it's a textbook example. High prices, little action, broken promises. And, we're at a crossroads and we risk turning in the wrong direction. And that's a luxury that most Americans and their families simply can't afford to do. We need to move past these empty promises and really drive towards real reform.
We do find some differences now when we look at progress since 2017. The percentage who believe drug prices have increased since that time, a majority, about 2/3 of U.S. adults see that, 81% of Democrats against 47% of Republicans. So Republicans a little bit more forgiving. When we mention President Trump by name, the percentage who believe the Trump administration has made progress on limiting the rising cost of prescription drugs, now a much more substantial partisan divide, that should come as no big surprise. 56% of Republicans against 8% of Democrats. But again, only 1/3 of adults overall see progress made by the Trump administration. So not high marks from U.S. adults, Tim, as far as what they've seen happening over the course of the Trump era regarding drug prices.
Yeah, Dan, what's striking here to me when you really dig into the data is there's this great, really political divide between Republicans and Democrats in terms of how they perceive the system at large. But when you dig into what the individual experiences are, what the family experiences are, it's blind to the left, to the right, or even the middle. There's very little that separates us in terms of the real life consequences. And that's why I think when we look at some common sense reforms to lower drug prices through Medicare negotiation or increase transparency or just pay for value rather than just volume, of procedures. I think there's hope. We can all have some hope that we can unify as a country behind some of these things that can really make a difference.
Back to some very recent polling that came in the immediate aftermath of the first presidential debate. Of course, we've got another one coming up here in a couple of days. We asked folks, which presidential candidate do you trust more to improve racial equality in the access to quality health care in the U.S.? 54% said Joe Biden, 38% mentioned President Trump. Among Black adults, substantially different, 84% to 9%. So 9 times more likely to trust Biden over Trump if you are a Black adult in the U.S., and we also found about a 2-to-1 gap for Hispanics. 60% said Vice President Biden compared to 31% who said President Trump. Tim?
And I just think back to the newborn and, at-risk wards of New Orleans with a 20-year difference in life expectancy. How many more Americans need to die prematurely? We really just do need the courage to act here.
Yeah, and that sets up this one pretty good. We've got strong alignment across party lines, across some different key metrics. Just kind of drop them in. The percentage who oppose political campaigns accepting donations from pharmaceutical companies during the pandemic, very similar. We've got upwards of 90% who support limits on the price of drugs that government-funded research helped develop. And then finally, we've got high levels of support for the federal government negotiating the cost of the COVID-19 vaccine once one is developed and approved for use. So I think this underscores your point, Tim, that in many critical aspects of the way in which we think about looking out for one another, the way in which we think about protecting our institutions, the way in which we think about how we need to make this stuff accessible to one another in a way that's efficacious in terms of its pricing, a lot more similarities than there are differences.
No doubt. I mean, what I took away from this, Dan, is that the pain that people experience, both of high prices and just the outcomes that aren't realized in our system, have bipartisan support to address. Perhaps not amongst the elected officials that we have today, but amongst those who elect them. And perhaps that's enough to move us forward.
One last slide, and I think this one's pretty important and pretty telling. Also, recent research. We, in a closed-ended fashion, not open-ended like some folks in some organizations, including Gallup, has done, but in closed-ended, we listed some different types of issues and had people rate if it was the most important or among the most important in influencing their vote for U.S. president. Our top two, which were a tie, about 2/3 of U.S. adults say it's either the most important or among the most important issue. was managing the pandemic. That one makes sense. And reducing the cost of healthcare. People might be a little surprised to see that. Again, clearly we find a nexus that exists between these two. But healthcare costs have not disappeared from the menu. Voters are, even as hopefully we're kind of nearing the point where we're going to get a vaccine by mid-2021. Most of us will have received a vaccination, hopefully, and we can start moving back into greater levels of normalcy. The broader issue of healthcare costs is still there. It doesn't go away. It didn't go away over the course of the pandemic. Yes, we find differences here among Democrats in particular. These are really, really high importance issues than they are among independents or among Republicans. But I think the overriding point, Tim, is that healthcare costs is neck and neck with managing COVID-19. It hasn't gone away. It's still a huge issue.
No, Dan, I think, the COVID-19 has really illuminated our, high premiums, out-of-pocket costs, cost of prescription drugs, just cost of services, in a new way. And the reality is that for decades, right, these high costs have been breaking the backs of the American family. And, going through the COVID-19 experience perhaps has sort of, raised them to a new level, to a new high. I'm optimistic that this is a top concern. And as I said in the beginning, we're here setting the agenda, establishing the leadership for what actions we will take as a country to address these challenges. And I think there's such an opportunity to move forward to a better place.
Great. Thank you, Dan and Tim, for those findings. Our next segment is a panel discussion with experts and voices regarding the policy and personal implications of healthcare across the U.S. Dr. Amit Sarpatwari is an assistant professor of medicine at Harvard Medical School, an associate epidemiologist at Brigham and Women's Hospital, and assistant director of the Program on Regulation, Therapeutics, and Law. Sarah Skipper was diagnosed with type 1 diabetes when she was 5 years old. Over the years, she has seen how diabetes, prescription drugs, and patient resiliency have evolved. One element of living with diabetes has changed drastically since her diagnosis, and that's the price of insulin. On July 26, 2019, Sarah testified before the Senate Committee on Oversight and Reform on the human costs of rising drug prices. And our last panelist is Dr. Richard Kroenig, a professor in the Herbert Wertheim School of Public Health at the University of California, San Diego. His research focuses on understanding how healthcare financing interventions can improve access, quality, efficiency, and equity in healthcare. From 2010 to 2016, he served as Deputy Assistant Secretary for Health Policy in the Office of the Assistant Secretary for Planning and Evaluation, working primarily on implementation of the Affordable Care Act. He's also served as Director of the Agency for Healthcare Research and Quality. Sarah, I want to come to you first. We just had Tim and Dan masterfully take us through a lot of data. Let's hear, now that we've heard from all these respondents, I want to hear from you as a person. Tell us about your story and why you wanted to testify before Congress about it.
Yes, well, thank you, Mohammed, and thank you for this opportunity. I am Sarah Skipper. What motivated me to speak in front of Congress was a few months before I got the opportunity. I was scrolling on Facebook, and my local news channel had posted the story about a young Black woman from Ohio who had passed away from rationing her doses of her insulin because she couldn't afford her next month's supply. And her mother actually testified in front of the same committee. And so just reading her story, and, she also has I have a younger sister who's also type 1 diabetic, and reading this young lady's story, she has a younger sister who's also type 1 diabetic. So I kind of felt like that easily could have been me. I really started to realize the difficulty of affording insulin once I became a college student. I had aged out of my pediatric endocrinologist, And I went to go pick up my prescription one day, and there was a note saying that she could no longer send me samples and that I needed to find adult care. And as a broke college student with no real resources, I just had to do what I had to do, and that was ration my doses. And my sister was living in Virginia at the time, and she had to send me insulin from Virginia, and then my grandparents would have to pay between like $275 to $300 for her supply because she had to send her supply to me. And in 2018, I was working a full-time job and I had insurance, and my sister, she was working somewhere else, and I couldn't afford my insulin. My insulin was $1,000 per month with my insurance from my employer, and it was just unaffordable. So my sister and I were sharing insulin from the same vial. One night we kind of got our wires crossed, and my sister hadn't realized I had already taken my dose and that I had left the vial out for her to take hers. And she ended up rationing her dose for me. And the next day she was in the hospital, and she ended up being hospitalized for 4 days, went into diabetic ketoacidosis, and, she almost lost her life. And I was just very angry during that time because I'm working and I can't afford what I need to live, and I have insurance and I still can't get what I need to live. And my sister put her life on the line. And so when the opportunity came to testify, I took it because I just felt like who else to tell my story in front of than the people who, run the country. So I definitely took advantage of that, and things have just really turned around. I've lived off of and still receive samples from, or not samples from my doctor, but like donations from people across the country, because still with my insurance, it's too much. But I don't have to share, and me and my sister don't have to use the same vial, but I mean, it's still unaffordable.
Sarah, thank you so much for sharing your story, and I know you're going to stick around with us. Amit, and so much of the work you do is about understanding kind of where the law and policy and healthcare really cross. All of the questions we're getting in our Q&A box really are primarily around one issue, which is how can costs be brought down in healthcare? Can you just sort of react to the data we shared? Of course, Sarah's story is not new to you, but also ideas around how costs can be brought down or are effectively maybe in some situations, examples of that working.
No, definitely. And thank you again, Gallup and West Health, for putting together this program, and Sarah for your compelling story. I think it's not unique. As has been heard earlier in the webinar, millions of Americans are struggling with affording their health care. And before delving into some of the solutions, I think it's important to worth expanding on a few points specific to prescription drugs. As we've heard, drug prices in the pandemic are not coming down. And I think one question in the Q&A was saying, well, what are we talking about? Are we talking about list prices? Are we talking about net prices, those prices after rebates are provided to ensure favorable formulary placement? And the answer is net prices are actually increasing, and it's despite what you may hear, this is a problem, and it's being driven by an increase in net prices on existing brand name drugs. So if you just took a basket of brand name drugs between 2007 and 2018, the net U.S. spending driven by price increases on that increased by 60%. If you're also seeing newer and newer products come to the market with higher launch prices, and now rebates aren't really an issue here because these are new drugs, and the annual average cost of a new cancer drug reached over $175,000 in 2018, over threefold higher than in 2000. So we've heard about the patient struggles, and I think one point that's important to address is there's an argument out there that this is the cost of progress, that this is the cost of developing transformative products. Now, you heard Tim mention the profitability of drug companies, and I'll look at there's a question in the Q&A about which drug companies and where that stat comes from, and I'll let Tim address that. But I think a separate point from this profitability, a separate point about this argument that it's needed, these high costs are needed to drive innovation is, let's take a look at all the drugs that have been approved by the FDA. And of all of them approved since 2017, about half were rated by expert organizations in Germany, France, or Canada to offer no or minor additional benefits over existing treatments. So when we're talking about later solutions and we're talking about trade-offs, we have to remember that the innovation we're getting for the high prices that are currently exist, that are really struggling, making families struggle to survive, that those prices aren't necessarily giving us the innovation we want. And so when we diagnose the problem, what's really going on? Why are we seeing surging drug prices? Well, it's pretty straightforward. It's because we as a country allow pharmaceutical companies to charge whatever the market will bear, and at the same time permit strategies that undercut competition and hinder payers' ability to provide counterweights that might reduce high prices. Now, I can stop here and we can talk about this a little bit further, or if you want me to get into a few examples of this, I'm happy to do so. So, Mohammed, I'll leave it up to you as to what you want me to do.
Yeah, no, go for it. Let's hear some of the examples that you feel kind of have been working, or suggestions you've come up with.
Yeah, so I mean, when we're talking about, again, I'll stick with the problems first a little bit and then get into the solutions. But when we're talking about restricting payers' negotiating ability, we restrict the Centers for Medicare and Medicare Services from negotiating on behalf of Part D plans. We don't allow Medicaid to exclude drugs from their formulary. Perhaps most importantly, in the pandemic time of things, when you think about the leverage the government has and the billions of dollars it is spending on COVID therapeutics, it's giving away that IP without any conditions on pricing. That sounds pretty ridiculous in the sense that we're now essentially making taxpayers pay twice. We are underwriting the most risky part of drug development, and we're not asking for anything in return. We should be asking for affordable access to these COVID therapeutics in return, but we even struggle to get access to what these underlying contracts are. They're black boxes, essentially, even through Freedom of Information requests about what the terms of these agreements are. And so really, increasingly, the public sector is playing an increasing role in later stage drug development, and we're not getting what taxpayers should get in return. It's called, the privatization of gain, but the socialization of risk. And so that's one aspect. And we're also preventing competition. And this is a huge problem because what we're essentially seeing in the case of some of these blockbuster drugs is they've been around for 20 or 30 years. You'd think that there should be plenty of competition for them, but they've developed this intellectual property thicket, these patents of, in the case of Humira, hundreds of patents that are blocking the product. This drug is 20 years old. This shouldn't be the best-selling drug in America at this point, but it is. And that's because we allow these strategies to delay competition. And there are ways to address that. There's been a lot of proposals at the federal level and a lot of action at the state level to try to increase negotiating ability and to promote competition. And in the case of, let's just start with promoting competition, it is unconscionable that Sarah should struggle to get insulin in this day and age. Insulin it was discovered in the 1920s, but even if you're taking a look at Novolog, like one of these recombinant products, still over 20 years old. Like, this shouldn't be an issue. So how do we get more manufacturers into the mix? Well, at the federal level, there's been proposals to have an Office of Drug Manufacturing within the Department of HHS, which could increase competitions by actually having the federal government make drugs, or working with nonprofits or working with generic manufacturers to make drugs. We've seen that that model could potentially work through a nonprofit called Civica RX, that as long as you ensure a stable amount of drug, and a stable amount of demand for a product at a stable price, manufacturers may be more willing to come into the market there. In the case of negotiations, I think a simple question is, why don't we do things the way other countries do? Which is to say that at a national level, we do and take a look at the value that the drug provides and pay based on that value. So plenty of other countries are getting much better deals on their drugs because they do this. And there is, from H.R. 3, the Elijah Cummings Lower Drug Price Now bill, there would be the ability to do this, which would basically, you could say that we do it independently and assess value, or we could tie it to an international price index. These ideas have been floated, even by the Trump administration, but it's mainly lip service right now, but we're not actually seeing the ideas move forward. And the question is why. Yeah.
And that's really great place to stop on the why. And our next speaker, of course, is somebody that was intimately involved with the how and the why during Obamacare. Rick, I want to just get your take on not only the data we've seen, but why has it been so challenging to bring down healthcare costs? You had an opportunity to really see it from an angle almost really very few Americans have. What are your thoughts on that?
Thanks, Mohammed. It's a really good question. More than 30 years ago, in 1989, I was a co-author on an article that described the U.S. healthcare system as a paradox of excess and deprivation. And sadly, that description is even more apt in 2020 than it was in 1989. We spend more than any other country, and we've just heard from Sarah and also the statistics from Gallup and West, tremendous deprivation. And I think it's, the problems are related, but also the solutions are different. I mean, with the Affordable Care Act, we made some progress on the deprivation part. 20 million more people got health insurance. There were some limits on, out-of-pocket spending for many Americans, but clearly a long way to go. Still 30 million people without health insurance, in some part because 19 states haven't expanded Medicaid, but also because health insurance is still very expensive. It's not affordable for everybody, and people still have high out-of-pocket spending. We need to make progress in those areas. Vice President Biden has made a variety of proposals that, if enacted, would lead to substantial progress. The excess side is, in a lot of ways, much harder to deal with. We've heard from Amit, very eloquently on prescription pricing, drug pricing problems. We should remember, drug prices or drugs that we buy in pharmacies account for about 10% of total healthcare spending. And then there's another, 5 to 7% that goes through hospitals. So it's not zero, but it's not the biggest part of what we spend, money on. And, you ask, why are prices so high? Why don't they come down? The short answer is there's no reason for them to come down. There's no advantage to hospitals or other healthcare providers to lower their prices. They don't get more business for this. And there is no effective government requirements for them to come down. Medicare and Medicaid do control prices. I'll talk about that in a second. On the private side, there is no competition or not effective competition and no government control. So that hospitals in this country get paid more than twice as much from private insurers as they do from Medicare. And in some states, 250% or 300% as much. And you ask, why is that? Well, it's because there's no reason for them to lower prices. So what do we do about it? What are the solutions? Little bits of progress maybe could be made on sort of better antitrust enforcement. But I think the only way to really make progress is to have public control on the amount that hospitals are allowed to extort from private insurers. And in the midst of the pandemic, that obviously is going to be tough to do because we need hospitals, and it's going to be hard to, have policy to change that. but it's something we need to be talking about. And then we'll just, a couple more seconds, 30 more seconds on the Medicare side. Medicare and Medicaid do a better job of controlling prices than does the private sector. They have a sort of bigger lever. But there are plenty of pricing fiascos in Medicare as well, of which the largest is, I think, Medicare Advantage, where Medicare Advantage plans are paid too much money. And then you ask why, and it's the classic problem of concentrated benefits and diffuse costs, that a lot of political pressure. But Medicare has made progress, and I think the looming insolvency of the Hospital Insurance Trust Fund, which is likely to go bankrupt sometime or be exhausted sometime in 2023 or very soon, will create an action-forcing event. And that strong public education and political leadership has in the past and can in the future overcome these problems. So
that's
thank
awesome,
you.
Rick. Thank you so much.
Yeah.
Amit, you seemed, I stopped you mid-sentence on the why. Do you want to kind of pick up and maybe respond to Rick as well?
If you can see me.
I shouldn't be able to see you.
I'll do a little bit more. I think Rick made some excellent points, and I think the interesting thing is, maybe prescription drugs are one part of the problem, but it's relevant to note that among some commercial health plans, or among some employers now, that they account for about a quarter of benefits that are being provided. And I guess in all of this, we have this question of incrementalism versus fundamental reform, and are we at a point where, at least I can speak specifically to the drug market, but are we at a point where we do need fundamental reform, and do we have the political will to get there? Is an interesting question, because the ideas are there. Increasingly, I think public imagination has been captured by the idea of the profitability of drug companies, not necessarily the value extraction by drug companies, the fact that a lot of the basic science, but also increasingly more of the translational work is being fielded by public payers. And so this notion of public return on public investment. And so I think that there are bold ideas that you've seen among progressive politicians, but what might be the most attractive way forward is something that I think bipartisan agreement should be there on, is this notion of ending abuses to extending market exclusivity. And this is a real problem when the whole arrangement in the pharmaceutical market is that you get this exclusivity as a reward for innovation. And at some point, that reward ends. And what we've seen is through patent thicketing, through product hopping, various strategies in which companies are exploiting various ways to reduce competition. Now, promoting competition should be a bipartisan agreement should be there for that. So there are reforms out there in terms of reforms to the patent system that would prevent abuses that I think you may want to start with before you try transformative reforms that would actually meaningfully help all Americans. It's not going to be a panacea, but this is a case where I think you can get buy-in across the political spectrum. Now, noting, of course, that the political spectrum is heavily influenced by lobbying, and that is not restricted to Republicans or to Democrats. It's across both sides of the aisle.
Rick, I want to ask, come to you last here to close out our panel, and then we'll move to the keynote. You're somebody that's been really in the hot seat, if you will, the crossover between politics and policy. This is one of the most difficult challenges Americans face. Even in our polling, a lot of people are dissatisfied with the healthcare system. But when it comes to solutions, the paths separate very, very quickly. Is there a common bipartisan ground, in your view, to address this issue of healthcare costs in the country? Have you seen hopeful signs that this can become sort of a transpartisan issue or concern, as Amit has alluded to?
It's a really good question, and I don't have a really good answer. I mean, clearly in Washington today, there's hardly anything that is bipartisan. We did have the CARES Act and some support for dealing with the pandemic. So we've had some examples of bipartisanship. In healthcare, we've had very few examples of bipartisanship for quite a long time. In principle, on the policy side, yes, there are policies, and Amit has discussed some of them. Some of the Medicare Advantage policies that have been proposed that could and should be supported by both parties. But whether we can get from that could and should to actual bipartisanship, I would not predict at this point. I think it's going to be tough.
That's a very honest and seasoned answer from a man who's walked the walk and tried to really solve some of these huge challenges for the country. It's interesting you bring up the CARES Act. When it passed, 70% of Americans supported it, and we actually saw the largest increase in approval rating for Congress that we'd seen in years. So the bipartisan actions definitely have their public opinion rewards, at least for the short term. I want to thank our panelists and move on now to our keynote by Dr. Marty Makary. Dr. Makary is a healthcare futurist, Johns Hopkins surgeon, and professor of public health. He's a frequent medical commentator on NBC, Fox News, and so many other sources. He's a leading voice for physicians. He writes for the Wall Street Journal and USA Today. He also advises policy leaders at the highest levels of government on healthcare and leads an advocacy effort to rebuild public trust in American hospitals. His best-selling book is The Price We Pay. It's a call to rebuild public trust in the medical profession at large. Dr. Makary, the floor is yours, sir.
Well, great to be with you, and good to be participating in this conference. There's a lot of folks on the call that I have a tremendous amount of respect for. And West Health has just been an amazing organization and a really great partner at Johns Hopkins in some of the research that we're doing. So thank you, West Health. Thanks for having me here. Thank you, Shelley, Leifert, and Tim Lash. And it's been great getting to know John and Zia and so many other folks. I want to talk about where we have broad consensus in healthcare, but where we don't talk about things, and we don't talk about things to participate in many of the important common sense reforms if we use the right lexicon. Instead of talking about medical costs, we should be talking about prices. Instead of talking about healthcare costs, the issue is completely reframed when we talk about hospital prices, medical prices, and drug prices. And in fact, if you think about the petroleum industry, as David Goldhill likes to point out, if you talk about petroleum futures, it's different from saying gas prices are going up. And I think fundamentally right now we have a pricing crisis because of pricing failures. Now there's broad consensus. When many of us fought hard in Washington, D.C. to try to get basic price transparency, and we were able to get the executive order on price transparency for 300 common shoppable services, and to get away from secret pricing in healthcare, evidenced by the secret negotiated discounts. That was a win for the American people, where remarkably, you saw almost no media coverage, and I think that's in part because it was bipartisan. And right now, the echo chambers of social media and cable news seek to polarize us, and I think there's broad consensus. When there is a pothole in a community, it's not a red or blue issue. It's who's going to do the work. It's a competency issue. In healthcare, we have a lot of these issues where we know we need to get at the underlying issues behind our reactionary approach. We need to get more research funding to address behavioral issues and some of the underlying public health issues in our communities that lead to illness. One of the greatest public health problems in the United States today that is not being talked about, that needs to be talked about, is the epidemic of loneliness, rampant among our seniors. This pre-existed COVID and has been magnified during COVID. loneliness affects one's physiologic reserves. And as we start to appreciate the role of frailty and the benefits of community, we're starting to recognize that a system that is entirely focused on the reflex of prescribing medications and doing surgical interventions is not the right system. It's necessary, it's just only part of the problem that we're addressing. A young generation of folks in healthcare are starting to say, can we do things differently? You know, I'm inspired by the students that we have, and they want to do something differently. If you think about millennials, if you know millennials or have millennials as kids, you know that social justice is a generational value for them. And they don't want to be a part of this broken system that we have. They want to be a part of rebuilding it. The blame game is going around in healthcare today. But this is not a system we designed. This is a system we inherited. Prices getting inflated for the purposes of secret insurance discounts, where hospital leaders routinely tell us that nobody's expected to pay those sticker prices, and yet we find people ravished all over the country by these bills, where the hospitals will even go to the extent of suing patients to garnish their wages, or in the case of UVA that we learned about yesterday through the reporting of Jay Hancock, seizing home equity. This is a system that has gone awry in a way where there is and should be broad consensus in the United States. This young generation of folks is starting to say, can we talk about treating patients differently? Can we spend time with patients? As a matter of fact, many of the senior docs I know that are highly respected sort of throw away or ignore the billing throughput coding cycle and just spend time with patients. And as a result, they discover things and can address things that otherwise get missed in our traditional billing throughput cycle. Maybe we need to start talking about treating diabetes with cooking classes instead of just prescribing insulin. Maybe we need to talk about treating back pain with surgery, with physical therapy instead of surgery, and with ice instead of opioids. These are ways in which we're starting to see people say, can we address the underlying issues? Food is medicine, yet we don't talk about food. Many conditions in the body are inflammatory conditions, and we've yet to scratch the surface on understanding the microbiome, for example. Where's the funding from the NIH in understanding what we eat, to understand the role of added sugar and processed food in causing general body inflammation, inflammation that we know is central to things like heart disease, a disease essentially of inflammation of the coronary arteries, Crohn's disease, ulcerative colitis, inflammatory bowel disease, rheumatoid arthritis, and you can go down the line. The number of conditions that we treat where there is some major influence of our behaviors, of what we eat, is vastly underrecognized and underappreciated and certainly underfunded. A new generation of folks are now saying, look, let's say no to the billing throughput cycle, and let's practice medicine in a way where we can spend time and build relationships. That's the model in the PACE Clinic. That's the model in Iora and ChenMed, Landmark, Oak Street. We're seeing these clinics pop up around the country, and primary care is now becoming a very attractive specialty to many of our medical students. It's becoming a well-paid specialty, as it deserves to be well-paid. It's becoming a forefront specialty within medicine. These are all positive trends. A lot of good things are happening. When we look at the problem of prices in healthcare, the public has a right to be very frustrated right now. 48% of all federal spending goes to healthcare in its many hidden forms. We've described that in reports that we've published at restoringmedicine.org. We've listed some of these reports. 48%, think about that next time you go to file your taxes. 48% of all federal spending, almost half, goes to healthcare in its many hidden forms. And then on top of that, the average American is paying $20,000 for healthcare insurance, and the deductibles are $2,500 or $5,000, sometimes $10,000. And it's no secret, those are not coming down next year. Okay, they are going to continue to go up year to year with no end in sight unless we can disrupt the marketplaces and address the fundamental problem in healthcare today. That is, healthcare is a marketplace with non-competitive markets, with price opacity. And when you see non-competitive markets as a citizen, as a user of those markets, the temptation is to want to set rules within those markets. But the fundamental transformation that's needed is to convert non-competitive markets to competitive markets. And that's what we're seeing right now. That's what the executive order on price transparency will begin to usher in. And as price transparency meets the demand in the marketplace, it will also foster quality transparency, which is even more important, a field which has been largely stagnant now for 18 years is the field of quality metrics. Now we're developing appropriateness measures, looking at practice patterns, gold carding physicians who are inliers and shifting all the resources to outlier physicians who have practice patterns of concern. I had a practice pattern of concern myself. For most of my career, I prescribed opioids far too liberally. Arguably, with good intentions and bad science, I feel terrible about how liberally I prescribed opioids, giving prescriptions to patients that should have never received any narcotics. And for those who may benefit from opioids, I gave them way more than I should have. It's important for us to have some degree of humility in understanding many of the areas where the research and the data is now showing us that indications we thought were broad are probably far more narrow, and that we should be addressing the underlying issues that bring people to care rather than simply reacting with prescriptions and operations. If we look at the idea of measuring appropriateness, it's been something that's been talked about but not really done. We have had an entire industry, the quality industrial complex, that has measured outcomes after we do things. We do an operation, say, for example, a knee replacement of somebody who comes in with knee pain, and we measure the quality of that care by the post-operative infection rate and the readmission rate, both of which are important, but it's all fraction of the quality of care. It misses the judgment of the physician in delivering that care. It misses the appropriateness of care. A third of knee operations may be unnecessary, according to some orthopedic surgeons. And so for simply measuring the consequences, looking at complication rates that by and large are in the range of 1% to 2% of patients that have those procedures, and missing the 30% of patients who maybe should have never had those procedures, we've been looking at the wrong things. Using general appropriateness measurement practice patterns, we're identifying doctors with high C-section rates in low-risk deliveries. We're identifying doctors that are have their patients on chemo and radiation therapy routinely within 2 weeks of a patient dying. If that's the case, the oncologist needs help. The oncologist needs better judgment in knowing when to pull up. We're looking at how often a procedure is parsed into 2 separate days or done as a staged procedure, or seniors are prescribed more than 12 medications in a primary care practice, excluding those with organ transplants. How often a child has an umbilical hernia repair when we know 99% of these umbilical hernias heal on their own with a normal closure, with normal growth and development by the time the kid turns 5 or 6 years of age. These are practice patterns that have been off the radar from pre-authorization or case management, but these are things that can be measured using practice patterns. So when we talk about value in healthcare, really we should be talking about the 2 components. Quality, measured not just with consequence rates, but with appropriateness measurement, and price. Price that's transparent, fair, and honest. If you think about the idea of shopping for a flight on a website where no prices are listed for those flights, I think we would all agree, Republican or Democrat, that that is absurd, that would invite price gouging among the airlines who would simply bill you after the flight. Now, I'm sure the airlines could argue that they don't know what their true cost is going to be. There could be a delay or a cancellation, or the pilot may experience more turbulence and have to bill more RVUs when they land and have to code the flight. But most people would say that's absurd, and you could build in the predictability of the risk into the price of the service. With Sesame Care, one endeavor that David Goldhill has started that I'm involved in, people will be able to see a price just like they shop for an airline ticket. Hospitals often argue that prices right now that they reveal either before or after are sticker prices, and nobody is really held to pay that exact price. We've learned that's not true. Our research has shown that 20 to 30% of hospitals were suing patients aggressively when they couldn't pay those charge master bills. And we started to go around the country asking hospitals to stop this egregious practice. In the spirit of using a plain English lexicon, we asked medical centers to stop not a high charge to cost ratio, but stop charging via price gouging. And instead of talking about collections rates with bad debt collection, we talk about predatory billing. People are coming in and they're losing the ability to sell their home. Their credit history is ruined. They can't afford food. They can't take care of their kids. These are consequences of price gouging in the marketplace. I've offered to defend patients who are sued in court pro bono, and I do go to court, and me and my team of millennials, where social justice is their generational value, we stand up for these patients, not as lawyers, but as medical experts, interpreting the bills and telling the judges that the patient is not obligated to pay when there's no agreement under contract law. We win 100% of the time. We've shut down about half of the hospitals in the country in their practice of suing patients, and we're going to keep going. This is a practice which violates the public trust in the medical profession and represents the most extreme form of medical prices out of hand. So that's a little bit of our work in value and in healthcare. So when people talk about value in healthcare, I think, Tim, it's useful for people to think about price and quality as the two driving components of that value equation.
Marty, thank you for that powerful message and really gave us a lot to think about. I now want to come back to Tim Lash for a call to action. Tim, again, is the Chief Strategy Officer and Executive Vice President of West Health. Tim, the floor is yours.
Great. So first, Marty, thank you for that. I couldn't agree with you more. As we think about addressing healthcare costs, you can't detach that from value, certainly not for procedures and healthcare services. And I would opine you can't detach it for drugs either. For those joining on the webinar, as you've heard today, we are facing dueling crises, one born of a virus and the other of a healthcare system that continues to be unaffordable to millions of Americans of every race, political persuasion, age, and income status. But while the virus is new, our high-priced healthcare system is not. It's been on its high trajectory for decades, and it has gone virtually unchecked by politicians and policymakers influenced by a very powerful special interest healthcare lobby that is happy with the status quo. Unfortunately, the status quo is profits over patients. The good news is that the country is waking up to the crisis of high healthcare costs, not just with outrage, but with their votes. We see it play out on the ballot box in 2016, and we will surely see that happen again in less than 2 weeks. We can't let our high healthcare price system go unchecked. It's an American tragedy. Stories like the one that Sarah shared today are all too commonplace. In every corner of our country, Americans of all ages are going without basic care or necessary prescriptions. People fear that one illness could put them into bankruptcy or wipe out their lifetime savings. And amid the pandemic, things are getting worse. If we fail to act and address runaway costs, they'll continue to climb, and our system of care will leave many Americans sicker and poorer. So what about future engagement? The question is, where do we go from here? How do we bring down costs and promote quality care? The two are not mutually exclusive, and anyone that is making it sound like it's either one or the other is being disingenuous. As our panel shared, there are several important things that can be done. Common sense reform is not an option, it's a necessity. Conversations like these are important, but only when they inspire action. Action from elected officials and policymakers, all healthcare stakeholders, and the public. We hope our surveys have given them the voice and the policymakers are not deaf to their needs and expectations. We will continue this work until voices are heard and common sense reforms are enacted. We face a moment of opportunity. We won't see this moment again. We are a unique moment in our nation's history, and never in our lifetimes have we been confronted with a public health crisis of this magnitude. Never have the issues that have plagued our healthcare system for so long been so front and center in the minds of Americans. People are considering their health and their well-being of others in ways that they have not before, and this shift in mindset is critical to addressing the problem. It's going to take all of us to address this problem. We need the strong public-private partnerships to address this challenge. Addressing the problem also is going to require input and action from government, academia, private companies, nonprofits, foundations, and the public. Too much is at stake for the status quo to continue. Thank you all for your time, and thank you for engaging in this conversation. And a big thank you to our panel for sharing their insight and expertise.
Thank you, Tim, and thank you to all of our amazing speakers. Great. All right. Tim and all of our wonderful speakers. I'm so sorry that my internet cut off here at the end, but I'm happy that none of our content got cut. These slides and all of the comments from our speakers will be available in about an hour's time, either at the link you received to RSVP, or if you contact organizers, we will make sure to get that to you. There's a resource box that has more information on the research we've done with West Health, as well as other work from our panelists. Again, thank you for joining us. I want to specifically thank Sarah for sharing her story with us. It takes a lot of courage to do that. We wish you all well, and we'll see you in the next webinar. Take care.